Why did DC choose to implement an administrative rule to expand the use of Medicaid instead of the more traditional state plan amendment? And what were the advantages in your judgment in going that route?
Okay. We went through the administrative rule, honestly, because it was less cumbersome than doing a state plan option change. And we had MCOs for probably 12, 15 years, and we were working on the fee-for-service component for the rest of the folks that weren't under MCOs. And when we did that, we had tremendous support from our Medicaid office. They were the ones that were actually pushing and said, here's a way we can get it done. And they were thinking and recommended that under the broad umbrella of EPSDT, that they could have an administrative rule and add the provider types and whatever else was needed. And then we could collect fee for service. They named our agency, which is OSSI, the State Superintendent of Education, as a public provider. So they set us up so that we could do all the billing for all the children, everybody that had Medicaid and in our Part C program. And we manage it, we have contractors and things like that. People had to get certified, et cetera, but it all goes through us. We do all the billing for it, for the fee for service. We actually borrowed from Virginia, which I had come from prior, and looked at a lot of the work they did, how they defined provider types, their codes, their rates. And when we worked with us to do our fee for service, we really modeled it after what they were doing. So we were able to make it a good rate, 150 a session. And certainly that brought a lot more funding into the system and brought more contractors into the system. Washington, D.C. has one of the lowest uninsured rates in the country. We have a pretty expansive program in Medicaid, and we do tremendous outreach. I think we only have about 6 or 7% that are uninsured in the district. So it's a significant source of the funding for the Part C program.
So tell me if I understood correctly, one, you didn't have to convince Medicaid, but did Medicaid come to you, or was this a gentle person's conversation that came to fruition?
It just started with a conversation from my agency to Medicaid. And we have a good working relationship with Medicaid, very close one, honestly. And they wanted to get it through so we could bill, because obviously we weren't collecting a lot of funding that we would be able to do it. So they were very supportive of it. There was no roadblocks. There was, questions and stuff, but they helped guide us. We gave them the technical information of what the provider does, what IFSPs are. I mean, all those sorts of things that you got to put in there to get it. And that did take time. That wasn't like, we worked on it a year and a half, I think, to get it all right, to get the ruling approved, to get the provider types accepted, explaining what they are, talking about special instruction and how difficult that is and things like that. But we were very pleased because we basically, the services that are offered through Part C were included in all the provider types. So it really matched.
So presumably in terms of the revenue it generated to you from Medicaid, and I'm assuming the district probably follows the same protocol as it relates to a state in terms of the state. For this purpose of the question, your increase probably was also occurring in your state share. Correct? Yes. Did Medicaid just accept that as an expense of their own, or was there any sort of trade-off between funds you already had to?
I think that Medicaid accepted it. I think we're a 70-30, so our state share is not significant for what you get back.
Right, right.
And in general, the thinking is it's such a good deal because of the amount we get.
Right.
They have worked extensively to expand Medicaid benefits in other areas too.
Yeah,
So
generally.
that was the thinking. I mean, we honestly had a very supportive DC council. We had a very supportive mayor who's one of our major programs is Thrive by Five. There's an intense focus on early childhood. We have universal preschool for 3 and 4 year olds. We have, a lot of programs, and a lot of folks are getting that universal preschool. So the importance of identifying children early and providing services is on the politicians' tongue,
Right.
and that helps.
So did you have any kind of I don't know if I want to say pushback or concerns expressed by the provider community in terms of, do they do any direct billing themselves? Do things all go through you or some other billing agent that
No,
works?
we do the billing ourselves. Um, they bill the MCOs because they're under contract, so they go directly for that. But the fee for service, which I think was of the Medicaid, maybe 25% were fee for service.
Mhm.
That's why uh, Medicaid established us. I don't think they really wanted it like any provider could just start doing it. It had to go through Part C. They wanted integrated with what what our law says and that sort of thing. So all the providers, and the rate was good, and it was simpler. We would do the billing for them. I mean, they just got to give us the information. We would pull it all out and do all the billing, and that way we automatically just paid them monthly without having to worry to get the money back.
Yeah.
We do that. We just pay them for the services, and we go back behind and
So
collect everything that we
you
can.
pay and chase.
Yeah.
Okay. Um, did you experience any challenges from the MCOs? And when you were talking about those as managed care organizations, I'm assuming we're talking about them as Medicaid managed care organizations.
Um,
They get their primary funding from Medicaid?
yeah.
Okay.
Yes, they do. And there are like two separate programs, the fee for service and the MCO. They're actually in two different departments within Medicaid. Um, Somebody else deals with them, but they've been around a long time. And honestly, from the beginning, it was in their contracts that you will serve, the children, and the mentioning of the Part C program. That has been a standard practice, I think, in DC from the beginning. So they're very cooperative to work with. We get pushbacks on some things and telehealth and things, but in general, it's been working out pretty well. So.
And can you speak to, I know you would probably say some of that history precedes you in a positive sense, maybe in a negative sense too, I don't know, but since all of this sounds incredibly positive, can you speak to how you've been able to continue to maintain that kind of relationship? It sounds like your Medicaid agency itself is quite progressive in terms of what they want to do and how they will utilize their resources as best they can to do that.
And I would agree with that. I think our Medicaid agency is pretty good about monitoring the MCOs, and I don't want to make it that it's so rosy and was so easy. We certainly have had children that MCOs said they weren't going to pay for, and we have a process to go through. And it's a very competitive business in DC. We have 5 MCOs. They were recently, DC will change MCOs if the performance hasn't been that great. And we have done that each time we've renewed. We've dropped someone or picked up someone new. And it's a very big part of their business, the entire, because Part C is one little piece, but I mean, they have all the healthcare for the whole city. And we're small, but still, it's a very, it can be profitable for them. So
Small but growing, right?
yeah.
Yeah. Um, I had another question right in my head, and maybe it'll come back. If you were advising other people of how to go about the decision making between your administrative adjustment versus a state plan amendment, what would you encourage people to do?
I think that the biggest thing is to develop the relationship with your Medicaid counterparts, the staff that you're working on. We have, I mean, the woman that led it for us and was our major proponent sits on the ICC. So she has been very involved in all the things about Part C, and she's in charge of all children's services. So this is a big part, and she's just been supportive, and it really has. I mean, it has helped tremendously. I've worked with other departments in Medicaid outside of this, and it's not been going as smoothly there.
And did you bring her in, or was she already there?
She was already there when I arrived. She's been there about 10 years, and I've been here 4. But from the very time I got there, she was talking to me about what we wanted to do, you know, what my predecessor and others at Aussie had mentioned to Medicaid and how they wanted to go about it and how we wanted to develop. I came right in when we were developing what the provider types were to put everything in with like a billing service to bill for us. So, and that they work directly with the Medicaid people and us to get the right definitions and, you know, the time, the pay, the codes, the subcodes, et cetera, and all that. And that's lengthy, but I just can't express it enough. The key thing is to have a good partner who understands what you do in Part C and why it's important, and that we do need to have as much funding as we can, you know, get sources for, so the children can get it. And DC doesn't charge family fees, and we don't bill insurance either, which I've been pushing that let's look at least billing insurance. They don't want to bill family fees.
Right.
Just something that they don't want to get into. But insurances, we haven't gotten there yet, but that's my next step.
Good. The question I was going to ask that I was sort of blanking out on was, how did you deal with public instruction as you, if I'm understanding again correctly, that you have a set rate, and that I'm assuming is inclusive of the range either of disciplines or service types? And was public instruction or the use of either special educators, early childhood educators, how does that fit in? Are they reimbursable in your system?
Yes, the special instruction is reimbursable under the fee for service. The MCOs do not reimburse special instruction.
Mm-hmm.
The special instruction has a little lower rate. It's $120
Mm-hmm.
a session, an hour, and then the 3 therapies are $150 an hour.
Okay.
That took tremendous amount of discussion.
Okay.
Because they're not licensed, you know.
Is that because it is viewed as an educational service?
That's part of it, and also that they're not licensed per se. And Medicaid was very driven that you're licensed as a PT, you're licensed as an OT, and we try to explain, yeah, but they're certified teachers and they have special instruction and stuff. And we did get it through. That was probably the stickiest point, but they did accept it as, you know, them as evaluators and paying for the evaluations and those sorts of things.
Great. How about you, Allan? You got anything that you wanted to say that we haven't asked you the right question?
No, but I think, you know, in dealing with Medicaid, I don't think that a lot of states realize the flexibilities that they have available to them. You know, as I hear from other state people, they, you know, and I guess Medicaid programs are all different and you can define what you want in it,
Mm-hmm.
but it doesn't disallow a lot of things that people think you don't have to do.
Mm-hmm.